Hi everybody, this is Dr. Derek Mahony, and tonight I'm talking about open bites in adults, what causes them, how can we treat them, which cases need surgery, which cases can we handle with a non-surgical outcome. Right? Just check all 4 Facebooks for me, please. So I'm posting this on all 4 of my Facebooks, Derek Mahony 1, 2, 3, and 4. It'll stay on Facebook for the next 4 days. Feel free to share it with your friends. It's a public profile. If you like it and you want to learn more, I will happily send you the articles I reference and a copy of these slides, but you need to email me for that. And the email is right in front of you, info@derekmahony.com. Please be specific. When you send that email, ask for the lecture notes and the slides associated with open bite closure in adults, right? So where I'm discussing options for treatment, I want to show you all the things I've used in my career. I'm doing this in a very short time frame, obviously, so it's a bit of a summary lecture. And I'll start by making this point. If you're a beginner in orthodontics, this is not a case for you to tackle, right? It's an open bite in a non-growing individual. However, as you get experience and you understand how to do arch development, how to make room for the tongue, and how to do active intrusion of the molar, this becomes actually a simple case. So let's go back 32 years to when I graduated. I would treat this case purely by incisor extrusion. So I would literally put my anterior braces more gingival, and I would get the patient to wear box elastics. Now, what have I noticed in those cases? Number 1, huge relapse. Number 2, increased chance of root resorption. Why root resorption? Because as I'm extruding the incisors, the tongue is still going forward and intruding them. So extrusion, intrusion, extrusion, intrusion, they're called jiggling forces. And those jiggling forces are what is going to increase the chance of root resorption. So I no longer focus my closure of open bite on pure incisor extrusion. Instead, I look at the research by Dr. Judy Ball, Nigel Hunt, where they look at stability of open bites and show that molar intrusion is a lot more stable than incisor extrusion. So what I'm going to teach you tonight is how I can intrude teeth in an adult so that that 1 millimeter of intrusion, not just the upper molar, but the lower molar. So if I intrude the upper molar 1 millimeter, the lower molar 1 millimeter, those 2 millimeters of molar intrusion give me at least 4 to 6 millimeters of bite closure. So in most of the cases that I would advocate surgery, I'm now happy to do non-surgical intervention, provided the patient follows my instructions and actually does their tongue thrust retraining. Because the main enemy here is not going to be the teeth moving, it's going to be the tongue causing the change in the jaw posture, causing the mandible to rotate backward as you have an anterior tongue thrust, okay? So if you like this lecture and you want to share it with your friends, please feel happy to do so. If you'd like a copy of the slides, you need to email me at info@derekmahony.com. If you miss this lecture and it's removed from Facebook, but someone talks about it, once it's been on Facebook for 4 days, I then move it to my teaching website where all the lectures are free. I'm here to share education. It is called eodo.teachable.com. eodo.teachable.com. You'll have a plethora of lectures on there. I have the free lectures, and there's over 100 of those. Average duration is an hour. You can do multiple choice questions and get CPD. I also have my full orthodontic mini residency, which is a 3-year program with 18 modules. I also have my full sleep apnea, sleep disordered breathing, bruxism, TMD, OSA module, which is over 2 years. And it's a series of 8 consecutive lectures. So, lots of stuff for you. If you like what I have to say and you like my teaching style, I'm all about sharing information. As long as someone gets good orthodontic treatment because I gave the idea or I gave the guidance, I'm a kind of happy guy, right? Okay, so what are you going to do with this patient? I mean, she is 33. She has a bilateral crossbite. She has a large open bite, and obviously she has a lowered tongue posture. In the words of Albert Einstein, when I teach orthodontics, I don't give you a recipe book. I want to give you the training to think logically on how you would treat that case. Many people would say, right, you need to use my brace because I invented it. You need to use my aligner because it's the best. You know, no, I don't really care what aligner you use. I've used a lot, and you know what? They all work the same. I don't care which brace you use. The teeth don't know whether you've used bracket XYZ, but the teeth do understand the correct biomechanics and the correct force level, right? So that's what I like to teach, not brand names, but education in the way you would do the treatment. I don't allow videotaping of this lecture, so it's copyright. So this is my my legal slide. However, certain slides I can send to you without the patient info for privacy. And I ask you please respect that. I'm doing this at no charge, and I want you just to share the information that will be posted on the live feed. Okay, so I've been in practice 32 years, and how have I tackled these cases in the past? Well, many times I would say to a patient, listen, you have a severe open bite, it's surgery or forget it, right? But now I know a lot more. So I can offer 90% of my patients a non-surgical intervention. Now I'll talk in the last slide of which cases still need the surgery. And if you like what I'm saying and you're ever coming to Australia, look behind you. That is the most beautiful city in the world. I moved my head so you can see the sun rising above the Sydney Harbour Bridge and my beautiful city of Sydney. I have 6 very successful orthodontic offices all around Sydney. Sydney is a big population now. We have over 5 million, and you know, I love it because it's very multicultural. I get to treat patients from all sorts of races and cultures. And if you're ever in Sydney, please email me and say, hey, Derek, I'm going to be in Sydney in 3 months, 4 months. I'd love for you to come and visit my office or one of my offices, see how passionate I am about what I do in practice, see the great results we achieve for our patients, and maybe learn something along the way. All right, so these are the topics I'm going to cover, and I'm going to cover them very briefly. I mean, this is really a 2-day lecture, but I'm doing it as a summary, okay? And it's late at night. I have worked a 12-hour day. My first patient was at 7, and I literally left my Rambouillet office at 7 to be here in time to this lecture at 8. So if you don't mind, I'm going to drink a glass of wine while I'm lecturing. I don't know when you pick that up. That is a very good wine. It's a wine I actually produced in my own vineyard. Let's talk about aligners. And aligners are very good for intrusion because you can get your forces exactly where you need them, but not aligners on their own. I like aligners with tabs, and I'll explain that to you. And this is a technique I've learned from my colleague, Chris Chang, and my colleague, Dr. Diego Peydro. These guys have really shown me how to make what would have been surgical open bites into non-surgical cases. I've done a lot of lectures traditionally with Dr. Kim, who developed the MEAW technique. And then I've done more advanced lectures with Dr. Sato from Japan on the MEAW wires. And thank God now with the newer wire technology, I don't have to do as many bends. But that's a powerful way to close these open bites non-surgically. I'm going to touch on that. You know, basic stuff. If you have an incisor that's like this, if you use a low torque bracket, by changing the torque, you're actually extruding the incisor, but stably, because detorquing a tooth closes an open bite, and it's much more stable than pure extrusion of the incisor. So I'll talk about that. In growing children, I do orthopedics, and I particularly like an appliance from American orthodontics called a rapid molar intruder, because that's like a a Jasper jumper, but with vertical. So when the patient closes, the springs, the nitide coil, pushes the molars away from each other. And again, as I said to you, if I can get a couple of millimeters of molar intrusion in the upper and a couple of millimeters of molar intrusion in the lower, I really get some serious closure of my open bite. But the stability is going to be very much related to the tongue. And I need to have that palate the right dimension so the tongue can fit there. And thank God for my wonderful oral myologist, Nada Karib. I love her to death. She works in all 6 of my offices, and I'd be lost without her with these cases. So hint, hint, if you're an orthodontist out there treating open bites and you don't work with an oral myologist, you are crazy. And I can send you a classic paper published in the American Journal of Orthodontics, actually, that looked at stability of open bite closure with and without myofunctional therapy. And obviously the much more stable results were those patients who trained their tongue to sit up rather than forward, right? I mean, I learned a lot of orthodontics from people like Bimbler, from Frankel, and they were big on muscle. And they used to have the saying that in a war between teeth, bone, and muscle, muscle is always going to win. So, I can show you how to straighten teeth, and I can show you how to expand a cross bite and how to close an open bite. But if you don't retrain that tongue, 100% relapse. So we'll talk about that later. And yes, I still do surgery, but the surgery I do is more Bill Arnett style, which is a differential of the occlusal plane. And I have fantastic surgeons I work with, but there's indications for surgery where I know I can't achieve the desired facial result with the movement. But if it's a patient who really has no concerns facial aesthetically, but has concerns just with function and chewing, I can pull those cases off without surgery. So, go back 30 years in my practice, 90% of these patients would be surgical. Go forward 30 years in my practice, like today, probably less than 5% are surgical. And that's amazing. It's like, a good deal for patients. And I've been doing this for a long time, so I'm not going to just show you cases that I just took the braces off and say, look how wonderful am I. I'm going to show you cases where we have had stability 10 years down the track. I think 10 years is a good benchmark to see exactly what you've done in orthodontics, to see whether this was all BS or it actually worked. So let's talk about the research of Bjork and Skeeler. And they talked about what's called forward or backward growth rotation. So a lot of these patients are backward growth rotators. And what we're trying to do is to change that backward growth rotation of the mandible forward. So if you look at the work of Sato, he's shown that leveling the occlusal plane is probably the best benchmark to check for stability of these open bites. And I totally agree with that. Because when you flatten that occlusal plane, followed by anterior mandibular rotation, you get a really good forward adaptation of the mandible. Because remember, if you're doing surgery for a high angle class 2, you don't actually focus on the lower jaw, it's the upper jaw. You impact the posterior part of the maxilla and you allow auto rotation of the mandible. So we can actually do that with TADs now and bonded hyraxes, but the principles are the same. And if I get a case that has a really short ramal height, I now do distraction of that ramus, and that's the surgical cases. And if you ever get a chance to listen to my surgeon, David Lycrum, he'll discuss with you that surgical side of things, which makes my life so easy because I don't have to worry about closing the bite. So my surgical cases are those where the maxillary and mandibular occlusal plane are like totally divergent, like bang, and I just level and align the dentition without trying to close the open bite. And my surgeon does all the hard work. He does like that posterior rotation. We then allow that to come forward. And all these cases need a genioplasty to give them a good facial balance. So I get very good surgical outcomes. But I'm here tonight not to talk about surgery, right? But I don't want you to go home thinking, oh my God, I'm born again. After this lecture, I'm going to tell my surgeon to bugger off. No, you still need a surgeon, right? And you need to pick the patients you're going to do what for. So, if you haven't read the classical research of Bjork and Skeeler, you need to. they put little implants on patients, and they took a lateral ceph every year, and then they superimposed those lateral ceph to see how the jaw grew. How they got ethical approval for that, God only knows, but it's a landmark research paper. And what did they show? They showed that the mandible tends to rotate either forward or backward, and you can see here Mr. Brachyfacial patient on the top, this guy. He has that short lower anterior face height, prominent labiomental furrow. So, that's a forward growth rotator. Tonight, I'm talking about my friend down the bottom here, who can hardly get his lips together even at gunpoint. Look at his open bite, right? And look at where his tongue's going to sit. Now, you see the guy at the top has that really square-shaped jaw because the tongue goes laterally. The guy down the bottom has that real V-shaped jaw because the tongue's never been there. So, you've got to start looking at it. But read that paper. It's like classic. And it really shows you that if you want to level that occlusal plane, you need to do it with good biomechanics. This is one of the best orthodontists in the world. And Dr. Kim, and of course, every orthodontist from Australia, from Korea is called Dr. Kim. You've got to pick which Dr. Kim you're talking about. This Dr. Kim wrote this really good textbook. So when I talk to you about TADS, I really quote his stuff because he's showing you that when you get a clockwise rotation of the mandible, right, you are increasing the mass of the upper jaw. Whereas when you get a counterclockwise rotation of the mandible, you actually decrease the mass of the upper jaw. So in other words, it's like a slow impaction of the gummy smile using TADS. So please get his book. I've read it cover to cover 3 or 4 times. I recommend it to all my students. It's excellent, right? And it really has a great chapter on the vertical dysplasia. So the closure of an open bite non-surgically using orthodontic mini implants. He is a professor and a chairman in the Department of Orthodontics in Seoul National University, and he lectures all around the world specifically on this topic. All right, so getting back to that first case I showed you, now, when I first started using aligners, I just did them on simple cases until I met Ivan Malagon from Madrid and Dr. Diego Peydro from Valencia. And when I saw what these guys were doing, I thought, my God, this is really amazing. So let me share with you how we could do this case, believe it or not, non-surgically and also without braces. So that's Dr. Diego. He and Ivan do a fantastic program in clear aligners. And if you understand the way things are going, if I was to fast forward 5 years from today, I guarantee you I will not have one fixed brace case in my practice. All my cases will be clear aligners. Why? Patients want it. I have less emergencies. I don't have wires poking and brackets coming off. Technology has changed, and you need to step up with that. And if you're interested, these guys do an amazing program which they call Clear Ortho International Program, right? But anyway, so let's look at this case. She's gummy. She's very narrow. She has a skeletal open bite, and she doesn't want surgery, and she doesn't want braces. Who has cases like that, right? So what can you do for her? Well, the Diego protocol is to first expand the upper jaw to get room for the tongue, start working on changing the tongue, and then start intruding the molars, right? So see how narrow that girl's jaw is? I mean, that tongue has never been up there. She's also got a tongue tie. So, you need to look at these things. And Diego taught me not to believe CLINCHECK, right? So if you're one of these guys who just sends your case to, I'm not having to go to Invisalign, any of the companies, and you let a robot or a technician or someone move the teeth, you'll be impressed with what they do on the computer. But a computer doesn't understand biology of tooth movement. So this was what Invisalign had proposed. And what did I tell you? I no longer extrude incisors because I know how unstable it is. And I understand I get root resorption. I'm doing this to the teeth. The tongue is doing that to the teeth. This, that, you get root resorption, and it's horribly unstable. So that's what Invisalign was going to give you, right? If you look at their CLINCHECK on that case, it's all about just using attachments to extrude your incisors. There's minimal expansion. I mean, that's just prone to disaster, okay? So look at doing a proper course in clear aligners, and look at this app. This is designed by Diego. I use it almost every day. It's called InV Ortho Pro, so Invisible Orthodontics Professional Site. And here you can get thousands of cases where you can do proper CLINCHECKs. Now, the modified CLINCHECK for this patient in the new protocol, now I understand that molars need to intrude. Guess what? I've taken my attachments off the anterior teeth and put them posteriorly. Does that make sense? Right? And we've asked the first series of aligners to do nothing more than expand the upper jaw. And that's what's good about aligners, because when you expand, the occlusal coverage prevents the extrusion. Whereas if you expand with a normal Hyrax, the teeth will tip and flare and cause the open bite to worsen. So, look at this case. I mean, that's what you can achieve predictably if you know how to plan your aligners. And look at the change in the upper arch form, right? And you think she's happy? Of course she's happy, because she's got a broader smile. She looks so much younger. She can now speak properly. That's the way we do it. Now, if you're not getting the results you want with pure aligners, right? I can always add to the aligners TADs. And I like to put my TADs in the IZC of the maxilla and in the superior oblique ridge of the mandible. This is my really good friend, Chris Chang, another amazing, fantastic orthodontist. He's the guy that taught Diego Peydro how to combine his aligners with the TADs, right? And he has an amazing journal. It's called Journal of Digital Orthodontics. It's free, 4 issues a year. I'm very proud to say that I'm one of the contributing editors. And if you email me, I'll send you the link. You can subscribe. Man, you learn a ton from that. So in this case, I want to talk to you about, again, the protocol of widening the upper jaw, then changing the mechanics to give you intrusion of the molar versus extrusion of the incisor. So can you see how the narrow jaw becomes that? Now the tongue's going to love that. And look where the TADs are. 2 in the IZC, 2 on the palate, and then you wear an elastic from that TAD to that TAD over the aligner. And what's that going to do? That's going to really beautifully intrude your molars, right? So you got to tell Invisalign how much expansion you need. You need to rotate and tuck your 7s in. And Diego will show you how to do this on his COPI program or his Invivo Pro. So rotate the 7s so you tuck them in, expand, and then intrude with the TAD and the aligner. And you just get amazing results. I'm going through this quickly because I only have like a short time to present it. And I haven't had dinner and I'm starving, right? So all the excuses in the world. Okay, this guy, Dr. Sato. Absolute amazing mind. Blows away some old concepts in orthodontics, right? He treats really difficult malocclusions in Japan that have open bites with severe crowding. And he does it using these mechanics. So look at this girl. Again, like the last 2 girls, high angle class 2 open bite, right? So again, if you're a novice, you're going to think surgery, forget it, blah, blah, blah. But like, think again, how can you intrude the molar and detorque the incisor? Well, look at the occlusal plane here and realize it's steep, okay? Now, Sato did excellent research, and I still don't know how this works, but my God, it works. If you see a skeletal open bite that has wisdom teeth, just remove the 4 wisdom teeth. And he's shown cases where doing nothing else but removing the 4 wisdom teeth has closed the open bite down by nearly half, right? And it's got, I mean, he's got an interesting theory on what causes the skeletal open bite, what causes the class 3. So do one of his courses, you'll understand. But he uses these boot loops, and he has increased curve of speed, and he has anterior elastics. Why? Because he doesn't want to extrude the molar. So this wire, if you have an increased curve in the upper, reverse curve in the lower, and an anterior elastic, what's going to happen when the patient wears the elastics, the molars intrude. It's beautiful, right? As you do those mechanics, you are then flattening that steep occlusal curve, right? Now, thank God, when I first did my Dr. Kim course, we had to bend these wires with stainless steel. My God, it was like, sore calluses and hours of doing just one wire. Now there's a new material called gum metal, developed in Japan, and it's really easy to bend, and it gives you better flexibility, and you don't have to do as many loops, right? So anyway, older type situation, you'd level in a line on your normal night eye. You would then bend your loops and get the patient to wear the elastics. And in this case, it'll be anterior elastics with a class 2 vector. That gives you really good molar intrusion without needing TADs. And then you put a detorquing arch in and bang, right? Now, not only is that close that open bite down, but it's flattened the occlusal plane. And if you look at the stability of those cases, they're the most stable of any open bite cases. So can you see how a face looks better? And that's not with any bicuspid extractions at all. This is with molar intrusion. That chin rotates forward. I mean, if she wants to look like Brooke Shield, you can always give her a genioplasty. But at the end of the day, look at that occlusion well after treatment. I mean, that's nearly 5 years later. Really stable outcomes. So if you look again at the condyles, lo and behold, those condyles have remodeled. And this is what Sato has shown even in patients who have things like rheumatoid arthritis. The worst patients you want are those who have idiopathic condylar resorption. Everyone goes running in those cases, right? But if you can get on top of that with a rheumatologist, and you can then level that occlusal plane and intrude the molars, let me tell you, a condyle will remodel. Don't believe all that bullshit that, it's an adult, so, you've got no hope of condylar remodeling. You absolutely do. This is a paper that Sato published. I mean, look at that girl's condyle. It's totally knackered, right? She's 32. She never had an open bite throughout her life. Then the open bite just appeared like in her 30s. And, that's not tongue thrust. So please, you're going to get some oral myologist who goes, hey, everything's tongue thrust, everything's tongue thrust. Okay, look, yes, we're going to have to retrain the tongue, but if this was a true tongue thrust, that open bite would have been there from day one. No, what this is wear of the condyle caused by idiopathic condylar resorption / chronic rheumatoid arthritis. And the treatment here is using the same MEAW mechanics, MEAW. And lo and behold, look at the condyle. So right and left, far left is where we started. Far right is 5 years or so post-treatment. And look at the condyle. Can everyone see? Little miracle? No, happens every day in my practice. That's what you want to show. And people will say, oh, that's, all make-believe because you're using a 2D x-ray. Well, guess what? Sato is published on MRIs showing the exact same changes. Okay, so please understand that is possible, right? Okay, my good friend, Dr. Kim. Kim does a really good technique. So you only need one TAD, right? Remember that last case I showed you? We needed 4 TADs, 2 in IZC, 2 in the palate, blah, blah, blah. But what Kim does, he designs this really good TPA with a big omega loop for the tongue. And he puts 2 little hooks on it. Can you see the little hooks, right? And then he puts just one TAD where there's really good cortical bone in the mid palate. And then he uses power chain from those hooks to the TAD. Are you getting it? So what that does is you can position it in a good center of resistance. And because you only need 1 mini implant, it's lost more cost effective. But what we're doing here is using the TPA with torque and intruding, again, the molar to encourage the auto rotation. Now, sometimes we take out the terminal molar. This paper, again, by Dr. Kim, which won the best poster at the Korean Orthodontic Association meeting in 2004, and I was there to watch this and, learn from Dr. Kim and buy his book. And I was like, you go to a course and you come back, oh my God, this is amazing. I can't wait to try this. Well, that's the sort of experience I've had with Chris Chang, the experience I've had with Ivan Malagron, with Diego Peydro, with, Dr. Kim. And, what he's showing there, if you've got to take a CBCT and you look at the mid-palatal bone thickness, and that mid-palatal thickness allows you to put that implant in. So when you put that implant in, you can get that active molar intrusion. So look at this girl's open bite, right? So here's a bit of a combo. Being Korean and being influenced by the other Dr. Kim who developed the MEAW technique, here what you're able to do is use a little bit of a combination of MEAW wires with the TPA and the mid-palatal TAD. And that allows really good control of your occlusal plane and your molar intrusion. So a bit of a combination technique. But look at these girls' faces. They're high angle class 2, retrusive mandible, small chin. As you intrude and rotate that mandible forward, what you're able to do is close the open bite. Now, during that time, we obviously want to change the tongue posture. And I'll talk a little bit about that, but you've got to work with an oral myologist. Okay, and if you work with an oral myologist, and so 2 things on stability of skeletal open bites in adults: level the occlusal plane, a la Sato, develop the apparatus so there's room for the tongue, and get that tongue to work up, because all its life it's been working between the gap. You get it, right? And you get like these amazing outcomes. So I like to place my mini implant more distally, and I need to extend my arch anterior. That really gives me fantastic intrusion, right? But you'll learn that when you do a course by Dr. Kim or read his book. But can you see here what's going on? You attach those hooks distally and gingivally. And if you do that and you compare the diagram on the left to the right, you'll see a better moment of force, right? So look, I've just quickly shown you how some severe open bites in high angle class 2 patients can be treated non-surgically, either with aligners and the right attachments, aligners and TADs, the MEAW technique, the concept associated with Dr. Kim's TPA with his single TAD, but with the correctly designed TPA with the hooks. No matter how you close this, up to you. The question is, how stable is it going to be? And I learned this technique from my good friend in Colombia, Dr. Peydro. He's a great Damon operator. He's a really lovely guy, actually. I'm so lost with COVID. I'm an international orthodontic lecturer that's currently unemployed because there's no international lectures. Thank God I still have successful practices, right? But the good thing about traveling, you meet these amazing people, and we don't all have, no one has the perfect answer. So don't think you do one orthodontic program and you learn it all. You're going to learn bias with just one program. You got to travel and listen to people. And Peydro, the way he helps retain his open bite, obviously we put fixed wires, everyone does that, that's nothing special, but he puts buttons on his canines and he gets his patients, when the braces come off, to wear elastics between those buttons. How good is that? So that's giving you that same stability of open bite closure and preventing tongue thrust, right? So that's what I do in these cases. And the second thing I do is what Nicole Schaefer showed. Nicole Schaefer is an amazing orthodontist. She works in a small little town in North Carolina called Boone. Mike Mayhew owns the practice. Mike Mayhew, like Nicole Schaefer, trained at North Carolina under the famous Bill Prophet. Mike Mayhew, I don't know, is he a better golfer or a better orthodontist? Mike, if you're listening, you're good at both, right? Mike was a pediatric dentist who then did ortho. And he loves Damon, and he loves interceptive treatment. If every orthodontist in the world was as good as Mike, it'd be a better world. What can I say? Anyway, Nicole came up with this really good retainer, which I use as a nighttime thing. So remember, I'm using a lot of TADs, right? And how do I use those TADs? Can you see in this diagram? If I want to intrude and I'm not using aligners, I'll use a bonded Hyrax, okay? Acrylic on the posterior teeth will slowly expand. The acrylic will stop the tipping. And as I'm doing that, I either have the TPA with one tad, a la Dr. Kim, or TADs in the IZC, a la Chris Chang, like you're seeing here. And then I can use 6mm closing coil and slowly intrude, right? But here's the deal. Once I've closed the open bite, I still leave the TAD in there. Why? Because the retainer I use, I get the patient to wear an elastic from the TAD to the retainer. You understand? So Nicole calls this an open bite hooked retainer. And I get mine made at AOA Labs. They're really good. So can you see what's happening here? I'm maintaining my expansion because I have acrylic on the palate. I'm maintaining my intrusion because I have more acrylic posteriorly than anteriorly. Can you see that? So anteriorly, I have no acrylic, but I have a body wire to stop the tongue thrust. Posteriorly, I have more acrylic to give me intrusion. And I have active intrusion because they're putting elastics on to their retainer when they wear it to the TAD, right? It's really, really good design. I slowly then take the TAD out after about 6 months. And then the patient still wears this retainer, but they wear it kind of without elastics. Now, that's the paper I want to send you, because the last thing I want to say tonight, anyone can close an open bite with mechanics. Anyone can retain an open bite with the right retainer and the elastics like Pomodo does. But if you don't win the war with the tongue, forget it. And this was a paper out of Portland, Oregon. It was published in 2010. I love reading this paper because their null hypothesis was, if you close an open bite in a non-growing individual, what was more stable? Those that just had tooth movement or those who had tooth movement with myofunctional therapy? And let me tell you, the myofunctional therapy was a lot more stable. Of course it is. Now, myofunctional therapy is like, like a buzzword in orthodontics, but yeah, man, it's been around for ages. I remember reading this book. This is where it all started, Daniel Garlinger. And, he published a book in the 80s, and it talked about teaching patients how to swallow with their tongue up rather than forward, right? If you want to get a good oral myologist, get someone who's trained in that organization, because they really understand the link between oral myology and orthodontics. I've given you a couple of websites here. Some of them have exercises on there for you, but you're an orthodontist, you're busy, you're not going to have time to do these exercises with the kids. I get Nada in, she's trained from this group, and she tells the kids, simple stuff, how to strengthen lip seal, how to breathe through the nose, how to put the tongue on the spot. Lips together, tip of the tongue up, breathe through your nose. That's what it's all about. Anyway, look, that's like a really short overview. If you like what I've had to say, two of the doctors who work with me, Sandy Gattas and Isabella Drilling, are putting a course together. It's in July. Now, it's by Zoom, right? So we're not doing live courses anymore in Australia, at this stage, because of social distancing and whatnot. So it gives the opportunity, no matter where you are in the world, to tune in on this. And I also have my MaxFax surgeon, David Lycrum. I talked to him about earlier. So he'll tell you like when we do surgery and what cases we do surgery for. But I'm going to cover in detail MEAW, TADs, aligners, everything I've talked about now. And on top of that, we're covering gummy smile and how we can reduce that non-surgically, right? So if you like what I've had to say, please tune in for that course. See that registration, courses@eodo.com. Go in there, they'll give you the information. But for the slides and for the references that I've quoted so far, please email me, info@mahony.com. And with that, I am going to have dinner now because I'm absolutely starving. Hope you enjoyed it. Thanks for tuning in. For those who are still not back at work, I really feel sorry for you. I'm hoping whatever's happening in your country with COVID, it finally goes away. I didn't realize how much I missed going to see patients until we had to lock down for 6 weeks. We only went back 2 weeks ago. And let me tell you, we are back to full steam. As I said, 12-hour day today. But what can you say? I love what I do. So 12 hours seems like 2 hours to me. All right, guys, thanks for tuning in. We will see you somewhere around the world or through Zoom. How good is Zoom? I've become a little bit of an expert on Zoom now because I was forced to learn that. So maybe that's a positive thing of COVID, if there's such a thing. Okay, we'll tune in tomorrow night. We have a lecture at 7, not at 8. So we hope to see you then. So I am going to end meeting, and any questions, please post them on the Facebook feed or email me. Happy to answer them for you. Bye.